on, thank you. So moving on to our next speakers, we had a rescheduling of our webinar today. So now we're moving to our workshop. Can we move on, right, Mr. Krishna?
Yeah, we can move to the next one.
Okay. So we'll move to our workshop, which is with Irem, Aktar, and Sulaiman Yildiz. Our speakers are Sulaiman Yildiz is a pediatrician, a doctor in Madrid, Turkey. He is past executive committee member of Association for Medical Education in Europe. Apart from daily clinical work, he is actively working on the medical education activities. He previously worked as a European student representative at the European Parliament and the Secretary General at European Medical Students Association. So along with Dr. Sulaiman, we would have also Dr. Irem Aktar. It's a fourth-year medical student at Istanbul University Faculty of Medicine, who's always eager to learn, grow, and contribute actively. So far, she has been working in European Medical Students Association for 4 years with a great interest in medical education in various settings, and she is currently serving the EMSA as a medical education director for the term of the year 2020-2021. She's an active medical education trainer and a soft skill trainer also by the EMSA. She had an honor of attending the AME conference several times as a part
Nadine?
She is particularly interested in internal medicine and nephrology, and she's participated in several congresses as well as clinical studies. Besides medicine, she has worked voluntarily in associations like Lion Club and AISEC. So you're welcome to start your presentation.
Thank you so much. Can you hear me well?
Yes, we can hear you.
Yeah.
Okay. Can you give me the right to? I think I do have. Okay. Screen share. So just a second. Okay. So thank you very much for the brief introduction. I actually met Dr. Sulaiman through EMSA, as you mentioned, European Medical Students Association, and he will be joining us in, I think, 15 minutes or so, but I'll mostly do the presentation part, then we can move to questions or any other comments that will come from our audiences. So I'd like to start with this picture. Actually, I didn't have the chance to attend this conference, but just to give an overview of the colleagues who actually helped me prepare this presentation and deliver some feedback besides Dr. Sulaiman Yildiz. So basically, to start with, we have seen a greater focus in medical education, especially in medical schools, on social sciences, medical humanities, and there was an increased attention to social accountability and globalization of medical education, as well as the widespread uptake of longitudinal integrated clerkship, and all beyond that, recognition and importance of student engagement. So medical education has definitely changed a lot, and when we check it, although yet we had so many changes, it was seen that medical education was more unprepared than other fields of education when we consider corona epidemic, as we really lacked bedside education, and it was really hard for our educators to find the replacement methods that we can actually compensate for this education. So when we track back medical education to the last 10 years, actually, this is the part that we discussed with Dr. Sulaiman, because he was the EMSA medical education director. He was in my position like 10 years ago, I think exactly 10 years ago. So he has come up with this idea that what hasn't changed in medical education, that it's still responding to a variety of challenging. And to give a name to those, like we divided into 4 sections, especially the increase in the medically related information as the evidence-based education has given more attention to it, and there are so many studies going on, so medical knowledge that we should know is like really a lot compared to last years. Also, the role of mobile technologies, like the integration of proper technologies into medical education, are given more attention, and these technologies are super important as they allow us to access to excessive and massive amount of information. So we are now using up-to-date beyond PubMed, for example, or so many other tools that are used, especially in teaching and learning as well. There's also the changes and challenges in the healthcare delivery models. For example, international interprofessional collaboration is given way more attention right now. Also, lastly, I think this is the most one of the interesting facts, interesting changes that we have seen, that the evolving role of the patient, that's because the patient has more information about their illnesses more than ever. So based on our sources, we developed these changes, the new horizon medical education, into 4 parts. So based on these 4 parts, we have come up with 4 major trends over this 10 years period of time. And we have seen that there's more emphasis on integration of information, changing learning situations, and authentic curriculum, and student engagement. Now, in the following slides, we will be basically focusing on those 4, and we will get into details regarding these 4 major trends that I think we should all be aware of to design our activities regarding teaching and learning in medical education. To start with, this is the first one is integration of information. So this is, I think this has started with the way that a medical educator has started to raise and give more importance to adult learning principles into their work on curriculum design, because the doctors that we are learning from are the specialists in their areas, and they do have great clinical knowledge, like no opposition to that, but they weren't really focusing on how to deliver this knowledge to students, how to conduct this properly, even undergraduate and postgraduate settings. So the educational theories, educational strategies that can be used actually to get this knowledge spread to the students have gained more importance, and we have decided, it has been decided to apply the adult learning principles more into the medical education context, and being way more important. Also, in the past, we actually had large discipline-based courses that you are learning, like physiology, pathology for 2 months, and then you're moving on to other subjects. But these blocks are, I think, already over, at least all over Europe. That's what I have experienced from my friends as well, except some countries, because it has been realized that we are not just connecting clinical situation to basic science principles, but we should use them vertically and longitudinally integrated together, so that we are not just learning one thing and we put it aside, as a human body is not working like that, basically. Also, while trying to have an integrated curriculum, the idea has actually started with the fact that, we can take medical students from their early years to the clinical settings that they will actually learn more about, but we can give them an overview. Now it has, I think, moved beyond that. That's really amazing to mention, because schools are now using curriculum mapping and software-driven content management systems to ensure that the information is not isolated in one course and is not just delivered by itself, but rather it connects with the other relevant concepts. Like even when we are learning basic sciences, for example, we are now learning more on to disease and how we see this information in real patients, so that we do have an idea on what we are going to encounter in the future. Also, regarding this integration, actually in the past, students were expected to connect all this knowledge, getting all necessary attitudes, behaviors to become a competent doctor. So they were basically the main factor that was thrust upon. But now faculties are working to create their education offerings to maximize the opportunity for students to learn basic principles and prepare to apply them in their clinical settings. So a student as a learner has really given way more attention, we can say that. As a result, we actually had the chance to apply the vertically integrated curriculum way better than last year's, and it's now, I think, mostly and more fully understood. So this kind of longitudinal integrated clerkships addresses actually 4 imperatives that we should be aware of. It basically starts with connecting educational structures to the science of learning, and it stems ethical erosion, improves health systems, and especially meets the sociality needs. So we just don't learn from books or some sources that are given to us, but we rather learn how to apply them to the patients, to society, to how to do it in a proper and ethical way, and how to serve the healthcare, how to survive and learn within the healthcare systems. The secondly is the changing learning situation. There's a term that I would like to mention here. This is social accountability, and it actually forms the essential foundation for medical practice and medical education, because I think in the past medical education was more like for us to become doctors, but at some point it was forgotten that we are doing this for society, for our patients. Basically, this is what we are doing. What we are, it's like a service sector. So social accountability especially brings that and says that medical education should address the needs of the society and should give the best qualified service to the society, as well as doing qualified research to address the disorders that society is facing. So it has been also shown that, like throughout many studies, that more training in underserved communities, so when we move from hospitals and when we especially go to rural areas, for example, is more likely to lead students to choose practicing in these settings in the future. Even if they're not doing this in rural areas, they're at least more aware of the societies that they will be in. Or you can say that, for example, oh, but that sounds super national, so that you just learn where you are at, or you just focus on one society. But it also connects with the globalization that it also connects with the globalization and while learning your nation, but with the qualified research and everything, you are getting into the international standards. So that I think it really relates to learn global and act local idea, so that you know the society that you will be serving in with the high qualified standards. Sorry. And also, medical education has changed in terms of new learning approaches, because the experience of students in the classroom and the clinical setting has really evolved, and traditional methods like the lectures have changed a lot. Like even in my faculty, we're doing more of, for example, flipped classrooms, that we actually study beforehand, and we actually come to the class with some beforehand preparation that really helps us to learn properly and more engaged way. And there are also many new approach tackles with simulation and e-learning. No need to mention, but Corona has also changed a lot. Like nothing will ever be the same, and distance learning is taking its advantages. And I think right now everywhere in the world is mostly delivering the sessions, theoretical sessions through Zoom or other conference channels, and then you just go to clinical practices at bedside, as there's not much way to replace that in medical education. But bottom line, we can say that medical education is not the education that we got used to it. We do learn throughout so many different resources that are basically online, or just requires us as students and as doctors to prepare more to the lessons to get more efficient results. Also, using technology, I think it's a really like long discussion topic, but it may relatively happen spontaneously. You can just say that even these slides are part of technology, like that's very obvious. But using technology is really important, and really using it properly in a way that addresses the structural needs and objectives that you should deliver, like basically giving the content in the right way. And blending it into teaching practice is the most important point. So this is encapsulated in the practice of instructional design and creating detailed specification for the development, evaluation, and maintenance of situations which facilitate learning and performance. So technology is not what we are aiming to reach, but technology is rather a tool that really helps us to reach the educational goals. So therefore, we do have two key areas of designing an educational model involving technology. Is basically designing things to use. These are your tools and materials, and designing things to do, the activities that will help students to learn way better. And both areas involve, of course, consideration of the of some questions that we will be discussing in the next slides. So when we are designing medical education with more technology involvement, there should be some questions that we should definitely consider. And the first one, who are your learners and what learning process work best for them? It actually addresses the different stages in medical education and the learner's capacity with technology and the learner's level regarding medicine, so that you can integrate this in the first question. And the second one, what they are learning and what performance context you are working with. We can, I think, consider this more into basic sciences or in clinical settings. So it's really important where you're actually using technology, not just to use it, but to use it in a suitable way that really addresses your needs. And third one is what content will be used, how should it be structured and sequenced. It could be some handout materials, slides, or some apps that you are all using together, especially for example, calculating GFR and stuff like that. So how you're going to use it and what kind of tools you need to deliver that content, and how you should be educating these students. And the fourth one is the instructional and non-instructional strategies to be used. It's basically designing and structuring the session as we have decided who we are going to teach, how we are going to teach, what materials we are going to use. Then we are at the point that why are we doing this? Like, what are our goals in the session or in the educational context that we are using? So it's basically the education, defining the educational goals and strategies that students should get out of that lecture you're holding. And the last one is what media and delivery systems will use, and also how will you actually conduct the design process. These are basically the implementation part of the session. And the important thing here is to mention that technology-based education or technology-involved education requires way more effort from both sides, like both students and both professors. And there's more preparation to be put in order to get efficient results. That's why we need to consider these questions before the implementation part, just to make sure that it will go all right. So you just use technology for something, but you rather use it to meet your educational objectives and to basically push the limits and go beyond the classical medical education. So there is also a model that I would like to explain in this part, because we have spoken a lot about changing learning ways, learning techniques. This is actually like Canadian, it should be Canadian framework, and it shows where medical education was at and now how it's moving. It was basically, just to give a quick overview, it was more teacher-centered teaching, and teachers were doing their lectures and students were information consumers basically. But now teachers are caring more about how students are learning, what they may actually need it, how can I do it differently so that students learn better. So a student as a learner has become more in the center. And as I said, there was more information-based learning, and we were basically gaining piles of knowledge. But now it has moved, I think, in many countries and many schools, problem-based learning, and even it is said that it's not enough. We should move more onto team-based learning or case-based learning models and platforms, so that students can use this knowledge, can apply this knowledge both in clinical and non-clinical settings, so that they just don't learn a knowledge, but they learn how to use it properly. Then there was a discipline-based curricula that we were learning all disciplines separately, but now it's more integrated together, and we are learning the connections. We're connecting the dots so that we can see a patient in the proper way that we should see it, because we won't just see a pathology or a physiology or just one system. We should be considering all of it when we are applying medical practice. And beyond that, medical education was more hospital focused. So you were seeing just one hospital and with your doctors, and you weren't really, I think, aware of what community needs and why we are doing the services, etc. So that I think there are many clerkships right now, that you can practice this also even with private schools, that they have to go to state schools to see what kind of patients that they will see in the future, basically. Also, this curriculum was way more standardized, that everyone was getting the same thing, which is good in that up to some extent, but there should be also some chances in order for us to improve in other fields that we actually really want to focus in the future. So it really brings us to electives. We either have it, I think, in many schools right now as just lectures or the clinical elective options that you can do even abroad, so that you can improve yourself a lot more during your medical studies. And the last one is apprenticeship approach. I think this will never change, because we have to see some people practicing and we have to basically mirror them. We have to reflect upon what they're doing, and we even have to fake them in order to do the best. So it's basically following your doctors. But now we do have a systematic curricula, so that you just don't learn from one doctor, but you have some set of objectives and goals to be achieved. And as a result, there's more standardized and more global curriculum, or more global expectations from a competent doctor, to put it better. And here we are at the third one. Speaking of how curriculum has changed, there is authentic curriculum that we should also mention. And this authentic learning actually refers to a wide variety of pedagogical instructions and learning materials that connects what students are learning from books, from other materials that you're providing, to the what's actually happening, what's occurring, what they should know in real life scenarios, or how the knowledge is clinically applied, how they should be using it properly, or what kind of methods or considerations that they should take regarding their clinical practices, because they're not written in the books, basically, and really mirrors the real world of active medical professionals, and it navigates them through the field, basically. Just a second. So to move on, I think with this curriculum, when we focus more on the real world and real side, we have seen more patients, and we are learning more on social and behavioral sciences that really facilitate students' awareness of their wider roles and address the potential impact of their own values and beliefs on practice, because we are not doing this for ourselves. As we said, we're doing this for patients, and just treat patients. We're not just treating a condition that patient just has it, but we are treating a human being, so that we should be aware of their psychology, for example, or their other needs that can actually help us solve their problems. So we don't just look at them as like just some pathology samples, but rather human beings that we can address more, assess that they might need. So at this sense as well, like the responsibility of the curriculum to help students to ask the right question to their patients and to the context that they are in, or finding the source of information to those answers and evaluating the answers. So that really promotes like outcome and competence-based education and trustable professional activities, so that students are not just learning one thing there and applying it, but rather having a view, like having a horizon that sees things in a wider aspect, so that you just don't do one thing, but rather encompass other values that doctors should actually gain. So at the same time, as we said, it really has so many multiple aspects and assets that we should have as doctors. There's so much knowledge and evidence being created for diseases, even for new diseases occurring, scientific developments, as we have seen in, for example, even coronavirus, that has brought a lot to the medical literature. With this authentic curriculum, like students are learning to decide the best, even when the times of uncertainty comes in, because we are not honestly gods, but we are a long-term learners, like lifelong learners, to put it better. So it really helps clinicians need to be able to deal with uncertainty of evidence making decisions. It also takes us to the assessment parts, because assessment has also changed, especially due to COVID, that programmatic approach to assessment and contributes to the, this this way of acting contributes to the authentic curriculum. And there's a holistic view right now, like we are not just giving students just to solve some tests or some MCQ questions that you choose among, but rather focus on formative and summative ways, so that we can conduct different activities and we can actually evaluate these assets that I mentioned, like to become a competent doctor, we can actually evaluate those if they have gained all necessary knowledge, skills, attitudes, and behaviors towards their patients. So it really encompasses all the things that we need in the future to become a competent doctor. And lastly, one part that we will mention is student engagement. I think this is a part that I'm the most interested in. That's why I started with medical education related activities. But overall, we can say that designing educational programs that engage students enhances the overall learning process for students. And learning is, of course, more enhanced, more students are involved. And with this way, we also know how to identify what we also know how to identify what we don't know, and this is really an important step in becoming a lifelong learner for a student. And lastly, designing educational programs that engage the student in the management and the improvement enhances the overall learning process, as has been given in Aspire, and even in Aspire Awards given by Amy. There's a special quota for student engagement if schools are promoting it, basically, or getting some students actually to give feedback in decisions, or even to take lead in decisions. The schools are awarded to that. So for the last part, for the student involvement, I would like to share a letter with you just to give an overview on how student involvement should be, because we are at, I think, in many schools in different levels of this letter. Basically, the first one is manipulating students, that we are told as if you are involved, but we are not. Secondly, decoration, like we're using students just to be there. They're taking in students to the important meetings, for example, like Dean's meeting or curriculum development committee meeting, but students are just there to watch. And the tokenism is like really similar. Students are in the same level of watching, but they're not, their input is not asked, but they're just there to be told that we invited students. So in these three parts, like, students are not really engaged, unfortunately. And this happens a lot in medical schools, like student involvement in decision making regarding their own education is unfortunately not regarded as something important. But there are also like other good developments that we can assess the other steps of the ladder that's seen here. And the fourth step that a school can be is like students are informed about what's happening, and they are given an action to do, like you should conduct this task, for example. That's also a good thing, because the student involvement, this is where student involvement starts, with administration or with any with any activity that relates to students, basically. And the fifth one is students are informed and consulted about their action. It's basically adults are saying that, or the administration is saying that, okay, we're gonna do this, and what do you think about this action plan? What do you think about this curriculum? Or what do you think about the next steps that we are planning to follow? This is like a bit upper that students' ideas actually ask on how it can be better. And when we move a little bit up, it's the sixth part. Adults starts a project or like an issue, and the shared decision is happening with students. So what differs from the last fifth one is that students are consulted, but students' ideas are taken into the utmost consideration to the last decision. So basically they're saying their ideas, we're going to do this, and student input is also put in, so that we are at the sixth step and we are taking the shared decisions actually taking. And the seventh one is student initiated and directed action. This might sound weird, but this actually happens with student unions, students clubs, like the EMSA, for example, European Medical Students Association, in local levels. You can start some projects, and if the faculty is, but it doesn't really come from the faculty, you want to do a survey, for example, or you want to start with a new representative representation council, for example, and it's led by students, it's initiated by students, directed by students. That's why it's the 7th step, and actually it really involves students' awareness on this topic as well. So this is basically most of the time the students, what the activities that student unions are conducting or students clubs. And the 8th one is actually is the utmost point. I don't think that any medical school is that level, or we cannot assess that really, but this is really the ideal one according to this letter theory, is that student initiators share decision making with adults and adults and partnerships. I think in that part it says the most important thing is that students are involved in this process. We can say that like they're involved in 40% of the process, and adults and the administrations are in like 60% of the process, so that because they have more knowledge and more experience, they're giving the best of what could have happened with the 60% of contribution. But then students takes the lead actually, and they also put input, so that we do have the utmost and ideal curriculum or educational activities that can be conducted in school. So this is like the utmost level of participation for students to engage in the school's activities and to deliver a meaningful feedback, so that school can improve itself and students can actually play an important role on to this. I think the importance of this has raised a lot, although there are so many gaps and so many schools are in different levels of this ladder, or even it's also up to the students whether to engage or not. Like we can discuss this separately as well, but there's a long way that has come so far, and this will actually help like eventually get the best medical education possible and help the medical education solve the problems and the challenges that it's facing basically. So thank you very much for listening. I know that it's been a long presentation, sorry for that, but we're really open for your input or any questions that you might have, so that we can have a sort of discussion or like facilitation.
Yes, I want to congratulations, very beautiful lecture, and I invite you to participate with our Association of Pediatric Education, European Pediatric Education, and if there is a member of your community which is interesting, I have sent the email, my email, and the website, and it's very important that future students were implicated in education. Your lecture was very interesting. Thank you.
Thank you.